Okay, so we'll go ahead and start with our next chapter, which is substance use, and we'll also gloss over gambling disorders and other disorders that may be added in the next DSM. There's quite a bit of content um, in this chapter, so there's a few things that we might skip by, but we'll try to cover as much as we can. So again, we're talking about substance use primarily here, and gambling disorders do fit into some of this biologically as well. But here we go. So let's talk about natural rewards. And a lot of this is related to neurotransmitter dopamine, which is going to provide the feeling of pleasure as well as create a memory to remind us to do something again. So naturally, when we eat food, when we drink water, we have sex, those allow us to feel pleasure. And they reinforce the behavior, so it's going to be repeated. Thus, it's kept our species surviving for millennia. And each of these behaviors is required for us to survive. So again, there are reinforcing properties of these behaviors because of the release of those neurotransmitters. Now, when it comes to the reward pathway, so what's happening when we, let's say, eat a taco? The reward pathway in our brain is going to be activated. That's going to be the ventral tegmental area. That is connected to both the nucleus accumbens, which you can see here, just again at the top of the brainstem. That is also, so right at the top of the brainstem. And then that's going to be, move this for a second. Okay, ventral tegmental area connected to the nucleus accumbens, and then the prefrontal cortex. So that's kind of how it rolls. And it's going to send information to these structures via its neurons. So there's neuronal connections. The neurons of this pathway or of the ventral tegmental area contain the neurotransmitter dopamine. Again, like we talked about, that's going to be released in the nucleus accumbens and in the prefrontal cortex. So these areas are very much full of dopamine, and when they're activated, they're going to release dopamine. And so its pathway is activated by when we do something rewarding. Okay, so we discovered this pathway when we studied rats. They were trained to press a lever for a tiny electrical jolt to certain parts of the brain. And so when that electrode was placed in the nucleus accumbens, they kept pressing the lever to receive the small electrical stimulus because it felt good. That's also called positive reinforcement. Again, when you do something and it is rewarding, you're going to do it again to receive that reward. When the electrode is placed there, the rat will not press the lever for electrical stimulus because stimulating neurons in a nearby area that does not connect with the nucleus accumbens doesn't activate it. The importance of the neurotransmitter dopamine has been determined in these experiments because scientists can measure an increased release of dopamine in this pathway. So we know that that is a neurotransmitter that's active in this pathway. And here's the thing, though, if the dopamine release is prevented, maybe by a drug, there's a variety of drugs that can decrease the activity of dopamine in the brain, or if they just destroy the pathway, the rat won't continue to press the bar for the electrical jolt. So we know that this pathway is associated with dopamine because of the activity in the brain and the fact that, again, when dopamine is allowed to flow and this pathway is activated, the rat will continue to press the lever. And we have quite a bit on this, so just stick with me here. So we have a concept called addiction. Now, this is going to be different than the disorders that I'm going to present to you. Substance use disorders are going to range from mild to severe. Addiction is a different concept. So just keep this in mind, in that just because whether somebody is a quote unquote addicted to a substance or not is not going to dictate exactly whether they have a disorder or how severe their disorder is. We're going to go through the aspects of the severity here in a little bit, but talking about addiction is important because that will constitute some sort of substance use disorder. So this is going to be a state in which an organism engages in compulsive behavior, even when faced with negative consequences. So this could be somebody that's seeking out a specific substance, even if they know it could they could end up in jail, they may die, they may get beaten up, because that behavior is reinforcing or rewarding. So the use of that substance, regardless of what it is so rewarding that they're willing to put themselves in harm's way to use it. And one of the major features of addiction is losing control or limiting intake of the substance. So the most recent research shows that the reward pathway may even be more important in craving associated with the addiction and not necessarily the usage. So it's the anticipation associated with using something. So for example, for me, let's say with tacos and Taco Bell, and this can be the case sometimes in that I can crave and want Taco Bell a lot. And when I'm actually craving it, that reward pathway is being activated, thus releasing some dopamine. So I feel kind of good. I'm craving it. I'm anticipating I'm going to go get Taco Bell. And then sometimes when you get that Taco Bell, it's not as rewarding or pleasurable as the anticipation that I was going to get it. And so we've learned a great deal about the biochemical, cellular, and molecular basis of addiction, and it is a disease of the brain. So it is a disease. All right, so we're going to talk about a couple of different drugs here. We'll talk about heroin first, and heroin is a derivative of morphine. Just to take it back a little bit more, and again, we're talking about opiates and opioids here. So opiates are going to be naturally occurring in the environment, whereas opioids are going to be synthetically manufactured from opioids or opiates. So you have three different opiates in that you do have opium, you have morphine, and you have codeine. And from these, a variety of opioids can be derived. So we have things like heroin, oxycodone, hydrocodone, Vicodin. I'm so sorry, I'm going to miss a couple. Fentanyl, carfentanil. So hopefully that gives you an idea. And initially, I forgot to tell you that opiates are naturally derived from the poppy plant. So heroin is an addictive drug, even though not everyone becomes addicted, and it is a depressant. So that means it's going to slow down your central nervous system. And it is pretty stunning, as I wrote here, that not all people that use heroin become addicted. Now, we all know that heroin is incredibly addictive. So there are individuals out there whose personalities and biochemical makeups can allow them, again, this is a very, very small number, allow them to recreationally use heroin. Again, for most people, though, that is not the case, and it is an incredibly addictive drug. So the environment and the personality of the user are important in producing addiction, and heroin does produce euphoria and pleasurable feelings and can be a positive reinforcer, again, by interacting with this reward pathway, and that is going to activate those neurons in the VTA, NA, and cerebral cortex, thus releasing dopamine and activating that pleasure reward system, and reminding the individual that, hey, this felt good. Let's remember to do it again. And when we talk about this is far more powerful than the taco I was just talking about. So again, we have quite a bit here, so please hang with me. We'll be looking at the right side in some of these figures. But okay, localization of opiate binding sites within the brain and spinal cord. So there are a variety of areas where opiates can bind to neuronal receptors, both in, the spinal cord and the brain. So this also kind of goes to why opiates are used for analgesic effects. So you just have a surgery, you get morphine, you have no pain. So again, this is why opiates can be used for both recreationally and pleasure, and also analgesically. So when somebody injects heroin or morphine, the drug travels quickly to the brain through the bloodstream. Heroin can reach the brain just as quickly as if it is smoked. Abusers also can snort heroin to avoid problems with needles. In this case, the heroin doesn't reach the brain as quickly as if it were injected or smoked, but its effects can last longer. And that is because sorry about this, I'm losing a spot. The heroin, it does take a little bit longer to be absorbed by that soft tissue into the bloodstream and then to the brain. But again, it can last longer if one does that. You don't hear about that very much in regard to people snorting or smoking heroin for that matter, but there are a few. So once it gets to the brain, the heroin is going to be converted to morphine. And that's going to happen through enzymes. And so again, it starts out as heroin, but then it will be changed to morphine, which can naturally bind to opiate receptors in certain areas of the brain. Again, all of these green dots. So morphine or opiates aren't going to either basically prevent the reuptake of something or an action like that, like other drugs will do. They will actually connect themselves to the receptors. We have naturally occurring opiate receptors in our brain. Part of the cerebral cortex, the VTA. Okay, so again, we have the VTA, the nucleus accumbens, and then again, the cerebral cortex, the thalamus, and again, we have the brainstem back here, spinal cord. The morphine binds to these receptors, again, in those areas. And again, thalamus, brainstem, spinal cord. The binding of morphine to areas in the pain pathway leads to analgesia. So again, if it's binding to, again, this VTA, nucleus accumbens, all the way up to the cerebral cortex, that's going to activate those pleasure, effects. Whereas if it is in the thalamus to the brainstem, down the spinal cord, that is what is going to block pain. So in regard to the reward pathway, you can see it binding here, okay, in the VTA and the nucleus accumbens. And then this is how it happens. Okay, a close-up view of a synapse in the nucleus accumbens. So there's 3 types of neurons that participate in this action. One that releases dopamine. Okay, so we have the release of dopamine. A neighboring terminal. Okay, oops, sorry about that. So again, releasing dopamine, you have a dendrite. So you have the receptor over here and and so you have the receptor, and it's an opiate receptor, and the morphine can bind to that. And let's see here, terminal on the right, that contains a different neurotransmitter, probably GABA, and the postsynaptic cell that contains the dopamine receptors. Opiates are going to bind to the opiate receptors, again, kind of in the yellow, on the neighboring terminal, and this sends a signal to the dopamine terminal to release more dopamine. So that is going to be how this works on a neuronal level. And also, if you're wondering, don't worry about memorizing that. I do not test on that, but I try to give a little bit of background. So yes, just as we talked about earlier with that electrical jolt, rats will also self-administer heroin. It does it through a small needle placed directly in that nucleus accumbens, and it keeps pressing the bar to get more heroin because it feels good, and it's positively reinforcing and is a reward. And if the injection needle is placed in a nearby area, in an area nearby the nucleus accumbens, they're not going to administer it, so it has to be in the nucleus accumbens. And they found that the dopamine release is increased within the reward pathway of rats self-administering the heroin. So since more dopamine is present in the synaptic space, dopamine-dependent neurotransmission is augmented, causing the activation of the reward pathway. So again, it's increasing the activation of dopamine in that reward pathway. Thus, the rat feels good and is reminded to press the lever again, and it does it. So here we go. So we have tolerance then. So we'll try to put all these concepts together. So we have tolerance. This is when drugs like heroin are used repeatedly over time. And this is when tolerance can develop. When somebody no longer responds to the drug in the way that they initially responded to it. So this could even be like, we could use alcohol, for example. The first time somebody drinks a beer, they might get a little bit buzzed, be a little bit drunk, but then they continue to drink pretty chronically over time. One beer is not going to give them that buzz anymore if they continue to drink. They might have to drink 2, then 3, then 4 in order to get that initial feeling. It takes a higher dose of the drug to achieve the same level of response that was initially achieved. So, yep, an example with heroin, it develops rapidly to the analgesic effects of the drug. And this is why, like, your Vicodin, your Oxy, your Hydro, and morphine, fentanyl it's pretty dangerous. And it's not addiction, even though many drugs that produce tolerance also have addictive potential. Tolerance to drugs can be produced by several different mechanisms, but in regard to morphine or heroin, it develops at the level of cellular targets. So when morphine binds to opiate receptors, so when morphine binds to opiate receptors, it's going to trigger the inhibition of adenylate cyclase. That's going to orchestrate several chemicals in the cell to maintain the firing of impulses. So what's going to happen is it's going to increase the impulses that are the firing of the impulses. So it's going to make sure that those impulses keep happening, thus more dopamine is going to be released. And again, after the repeated activation of these receptors, the enzyme is going to adapt so the morphine can no longer cause changes in cell firing. So the effect of a given dose of morphine or heroin is diminished. So again, once it activates that, it adapts to it and it's no longer able to be activated in the same way. You need that much more morphine or heroin to activate that to get the cell to fire. So again, if you just understand, even I know there's that cellular piece, but even in regard to, again, the example I gave with alcohol, if you've got that, then you have more than enough information for this. So some of the brain regions regarding morphine tolerance that are involved. Again, areas of the brain separate from those in the reward pathway are in the thalamus and the spinal cord. Both of these are important in sending pain messages and are responsible for, again, those analgesic, pain blocking effects of morphine. The parts of the reward pathway involved in a heroin or morphine addiction, again, are shown for comparison. So again, you have the ventral tegmental area, nucleus accumbens, but you also have, again, the thalamus and brainstem. Okay, so that's tolerance. We also have dependence. So as somebody continues to use heroin, dependence also occurs. This is going to develop when the neurons adapt to repeated drug use and only function normally in the presence of the drug. So they get so used to being activated by morphine being present that they cannot be activated without it. So when somebody stops using that drug, there's some physiological reactions that are going to happen. And these can be mild, like for caffeine, or life-threatening, like for alcohol. This is known as the withdrawal syndrome. In the case of heroin, withdrawal can be very serious and the abuser will use the drug again to avoid the withdrawal symptom. Again, because they're having those withdrawal effects because, sorry, I'm shifting in my desk, because those cells are not being activated without the drug. And we'll talk about a couple of drugs with withdrawal, because that's actually a diagnostic. You can actually be diagnosed with withdrawal depending upon how you're presenting to a clinician. But when we talk about this withdrawal syndrome, yeah, and it's usually the withdrawal symptoms of a drug are going to be opposite those of the symptoms of when somebody uses the drug. So for example, with alcohol, when somebody uses a drug, it's depressant, it's depressant in nature, in that it's going to slow everything down. It's going to calm people down. It's going to slow speech, slur speech. It's going to put somebody to sleep. But when they're withdrawing from alcohol, the effects are going to be different in that everything's going to speed up. They might get jitters. They might throw up. There are high rates of anxiety. Seizures are possible. And random fact for the day is that alcohol is the only drug from which you can die directly from the effects, the withdrawal effects of it. Now, of course, there are always complications with other drugs and withdrawal that can kill people, but just from the substance itself, alcohol is the only one you can die from the direct effects of. And those direct effects, they are basically seizures. And so somebody that is a longtime user, they may have seizures when they're withdrawing from alcohol and die. And so usually the advice is for somebody that's withdrawing from alcohol is to take them to the hospital because they can basically receive a depressant, something like Ativan, so benzodiazepine, that's going to decrease the severity or the presence of those seizures and help them withdraw from the drug more safely. Okay, so going back to morphine and dependence, again involves separate areas of the brain. It's going to be, okay, so whereas tolerance, much more associated with the spinal cord and brainstem, the dependence is going to be associated with the reward pathway. And so the parts of the reward pathway involved in heroin or morphine addiction, again, are shown for comparison. The withdrawal symptoms are generated when the opiate receptors in the thalamus and brainstem are deprived of morphine. So again, that gives you a little bit of an idea in regard to tolerance and dependence. My alcohol addiction, if it's easier for you to remember, that's totally fine. Yes, in the PowerPoint, we have the morphine example, but I know that I'm getting into some of the nitty gritty. So if you know the basic ideas that I'm offering with alcohol, you have the entire concept of tolerance, dependence, and now we're going to delineate between addiction and dependence in this field. In other fields, in other areas of study, it might be portrayed differently, but this is how we conceptualize it. So different parts of the brain are responsible for addiction and dependence to heroin and opiates. So the areas in the brain underlying the addiction to morphine, that's going to be the reward pathway, and then dependence, again, thalamus and brainstem. So this is what's wild is you can be dependent on morphine without being addicted to it. But if you are addicted to it, you're most likely dependent as well. Okay, and when we initially talked about addiction way back up in the PowerPoint, this is when somebody compulsively uses a substance, they cannot stop, there's a lack of control, even in the face of negative consequences. Okay. So again, if somebody is addicted, they're probably dependent. It's especially true for people being treated chronically for morphine or for pain associated with terminal cancer. They could be dependent on the drug if it's stopped and they suffer withdrawal syndrome, but they're not necessarily compulsive users. And so they're not addictive. So again, if they've been on Vicodin for a while and they're taken off of it, they probably have some withdrawal symptoms, but they probably are not going to seek out additional Vicodin, even in the face of negative consequences. Okay, so we'll talk a little bit about cocaine. Let's see where we're at here. Yeah, we'll talk a little bit about cocaine and then keep rolling. Okay. So when we talk about cocaine, it is an addictive drug. It is a stimulant. And like heroin, not everybody becomes addicted. There are people that recreationally use cocaine, but with the advent of crack cocaine, that is going to be the freebase. The rate of addiction has increased considerably. So when it comes to crack cocaine is a derivative basically of cocaine. And really the difference is just procedural in nature. In order to make crack cocaine, somebody puts a little bit of cocaine, baking soda, and water in a frying pan, fries it up. It is going to crackle and create crack rocks, which are then smoked. So the difference between snorting and smoking cocaine, there's different addictive liabilities. Usually when cocaine abuse involves snorting the powder form, that's the hydrochloride salt. It's processed, or that's how cocaine has predominantly been used. When it's processed to form the freebase or crack, it can be smoked. So when you, again, heat that powder form of cocaine, that will destroy it, and the freebase can be volatilized or smoked at high temperature without any destruction of the compound. So smoking gets the drug to the brain faster than snorting does. So as you can see here, okay, so when somebody smokes cocaine, so when somebody smokes crack, it goes directly from the lungs to the heart to the brain. I'm so sorry about my PowerPoint issues. So again, directly from the lungs, heart, brain. You snort it, it has to go again to the bloodstream, heart, lungs, back to the heart, brain. So it takes quite a bit more time. Snorting requires the cocaine travels from the blood vessels in the nose to the heart, where it gets pumped to the lungs and to be oxygenated. The oxygenated blood, the red arrows carries the cocaine, carrying the cocaine travels back to the heart, pumped out to the organs of the body, including the brain. However, again, smoking bypasses this, goes directly from the heart to the brain, and the faster a drug with addictive liability reaches the brain, the more likely it'll be abused. It's that much faster of a reward. The time between taking the drug and the positive reinforcing or rewarding effects that are produced can determine the likelihood of abuse. So the faster, usually the more likely it'll be abused. So in general, we'll just look at this fairly quickly. When somebody smokes or snorts cocaine, it'll reach all areas of the brain. It'll bind to sites, again, in yellow dots. So the ventral tegmental area, nucleus accumbens, and the caudate nucleus. Cocaine binds, especially in the reward areas, as we can see here. In other areas, like the caudate nucleus, can explain other effects. Some like repetitive behaviors, pacing, nail biting, scratching, some like the jitteriness. Okay, and similar to heroin, it's going to bind in sites rich in dopamine synapses, like the VTA nucleus accumbens. And again, it can be seen down here. Dopamine is released into the synaptic space. The dopamine binds to dopamine receptors, as you can see here, and then it's taken up by the uptake pumps back into the terminal. Cocaine, the yellow, binds to the uptake pumps and prevents them from transporting dopamine back into the neuron terminal. So basically the cocaine is preventing the reuptake or vacuuming back up of any remaining dopamine, leaving more dopamine in that synaptic space, and thus resulting in more dopamine transmission. Okay, in regard to dependence, cocaine is going to bind with the reward pathway, and as a result of its actions, again, in that nucleus accumbens, there increase impulses, leaving it to activate the reward system. It can be activated even in the absence of cocaine. So like when somebody's craving, again, I talked about craving Taco Bell, same thing here. If they're craving cocaine, that can also be activated and somebody can feel pleasure. As people continue to use cocaine, the body's going to rely on the drug to maintain rewarding feelings. The person's no longer able to feel the positive reinforcement and pleasurable feelings of natural rewards. So again, as they cannot no longer feel rewarding feelings as a result of the coke, it's even harder to feel the rewarding feelings of natural things like food, water, and sex. So their overall levels of pleasure are going to go down. It's going to be that much harder to feel good about even natural things around them. They're only able to feel pleasure or normal by using cocaine, thus becoming dependent. And in the absence of cocaine, again, anhedonia, the inability to feel pleasure, and depression can emerge as part of the withdrawal syndrome. Again, that's the opposite of the effects of cocaine. And again, we're only talking about one neurotransmitter with both of these drugs with cocaine. There are other neurotransmitters that are involved as well. So the user is probably going to go back to cocaine. And unlike the example for morphine, cocaine addiction or craving and dependence, anhedonia both involve structures of the reward pathway, which is a little bit different than morphine. That's going to include both the reward pathway and the spinal cord. Let me make sure that I didn't screw something up here. Okay. Okay, let's see here. Okay. All right, so some of the substances included in the DSM-5 text revision. All right, we have alcohol. And again, even though we think like, oh, I wouldn't ever have a substance use disorder, well, you probably actually do. We'll go through a few of these. Yes, alcohol-related disorders, caffeine. Again, so maybe you have an issue with caffeine. We'll go through, again, we'll go through like a lower level one like that, even though it is still substance related and addictive. Cannabis, so your marijuana, hallucinogens, or inhalants, opioids, sedatives, hypnotics, stimulants, tobacco, and other. I always have a problem with the tobacco area because tobacco is not the addictive agent in cigarettes, so to speak. It's nicotine. Because again, like in your vapes, there is not tobacco, it is nicotine. Nicotine is the psychoactive chemical that is it's the chemical that you can develop tolerance, dependence, and addiction toward, not tobacco. But that's just an argument with the DSM that I have. Then we have other. All right, so to define what a substance is. Okay, so it's any natural or synthesized product that has psychoactive effects and can change perceptions, thoughts, emotions, or behaviors. So again, anything from alcohol to caffeine to nicotine to cocaine to peyote to LSD to psilocybin, all of those are substances. Now, I would also make the argument that at some point, we're going to have to potentially consider different types of food. We may need to consider different like processed foods. We may need to consider sugar, because even like with sugar, for example, it does have psychoactive effects. It changes perceptions, thoughts, emotions, and behaviors. It is stimulating in nature. It increases, well, it for a while, it increases or enhances positive emotions. It potentially increases energy as well. And so as a result of that, it does change our psychological status, so to speak. But those are not included right now. Substance use disorder. This is when there's a pattern of negative symptoms resulted from continued substance abuse. And I apologize for the interruptions, but nonetheless, okay, there's a pattern of negative symptoms resulting from continued substance use, and a diagnosis does not require physical dependence. So when so you can be diagnosed with substance use disorder, there's substance intoxication, and there's substance withdrawal. So substance intoxication is going to be a temporary diagnosis. So this would be if somebody were to present to a clinician and they are under the influence of a substance. So this is the development of a reversible substance-specific syndrome, again, of those mental and behavioral changes that involve perception, euphoria, cognitive impairment, impaired judgment, physical and social functioning, mood lability, belligerence, or a combination. So these are the effects of being under the influence. Taken to the extreme, intoxication can lead to overdose, significant morbidity, and risk of death. Yes. And the effects of intoxication are going to depend on what type of drug are we using, how much have we used, what is the individual's biochemistry, and what is the setting. That's going to influence how a drug's intoxication effects impact a person. But nonetheless, you can be diagnosed with this. And again, it's for situations in which an individual shows up to a clinic and they are under the influence. Maybe they are put into an inpatient facility and they're under the influence. Maybe their caseworker finds that they are under the influence. So that's what this diagnosis is for. Also, substance withdrawal. So again, we got three here. Withdrawal refers again to the substance-specific physiological effects, symptoms, and behavioral changes caused by stopping or reducing the intake of a substance. And again, there has to be significant distress or impairment in functioning. Most patients with the withdrawal, they do recognize that taking the substance again is going to reduce their symptoms. And in some cases, it'll make them feel normal. Even though some patients with the syndrome have a substance use disorder, some drugs like opioids, so we might be talking about like Vicodin, oxycodone, it can result in withdrawal symptoms, even if it's prescribed for a legitimate, for a legitimate medical reason, even for a brief period of time. So if you're taking, a heightened dose of oxycodone for a week as a result of some sort of surgery, that's long enough to actually develop dependence, a physical dependence to the drug, resulting in withdrawal symptoms. Doesn't mean you're addicted and you're seeking out the drug anymore, but you might have some withdrawal symptoms. And withdrawal symptoms that develop following appropriate medical use, they're not considered criteria for diagnosis of a substance use disorder. So you do have to find out, is this the result of a prescribed medication that has ended and the individual's suffering from some physiological symptoms from the withdrawal? And again, you might want to look to make sure, like, okay, in a couple weeks, we'll consider this again, or if there's any seeking out of additional oxycodone, then we can address it, but it's going to end and there will not be continued use. And it is the opposite of the intoxication symptoms. So like I was talking about with alcohol, it's going to be opposite of depressant symptoms. It's going to be stimulating symptoms. Again, things like jitteriness, not being able to sleep, seizure, things like that. Okay, so we have substance use disorder. Again, and there is one of these for every single disorder. So let's talk about alcohol first. That's because it's so common. So common. So so in order to be diagnosed with substance use disorder, to have a mild substance use disorder, you're going to have 2 to 3 of these symptoms. Moderate, 4 to 5, severe, 6 or more, and there's 11 total. So we'll start with alcohol and we'll do a couple others. So with alcohol, okay, there's a problematic pattern of alcohol use leading to clinically significant impairment or distress manifested by, again, at least 2 to get a mild one, are the following occurring within a 12-month period. So all of these symptoms have to have occurred in the same 12-month period. They don't have to occur over a 12-month period, but they had to occur within the same 12-month period. There can't be something that happened 5 years ago and then something that happened 6 months ago. You can only consider symptoms in the last 12 months. So you've taken larger amounts of alcohol over a longer period of time than was intended. So you've started drinking more and more alcohol. There's a persistent desire or unsuccessful effort to cut down or control alcohol use. Again, hopefully what's on the screen for you, you're seeing that it's pretty similar to what I'm reading in regard to alcohol. Most of the criteria across the board for every single substance is going to reflect what you're seeing on your screen, even though there's little tweaks for every drug, but for the most part, they're all similar. So you want to cut down the amount you're drinking, or you want to stop using it. There's a lot of time spent in activities to obtain alcohol, use alcohol, or recover from its effects. So maybe you're hungover all the time. You're spending a lot of time recovering every single day from it. You're craving, or you have a strong urge to use alcohol. You think about it all the time. When am I going to have a drink over my work hour? I can't wait for my drinks tonight. There's recurring alcohol use resulting in a failure to fulfill major role obligations at work, school, or home. So maybe you aren't getting to work on time because you're hungover. Maybe you're getting drunk at work. Maybe you're not going to class because you're hungover or you're drunk, or maybe you're missing out on things with your family because you're drunk or getting drunk with friends, or you're at the bar all the time. Continuing to use even when it causes problems in relationships. This could be with a significant other, it could be with friends, it could be with parents, it could be with children, but it's causing some sort of problem in the relationships that you have. You start to give up important social, occupational, or recreational activities because of it. Maybe you used to play on a rec league every Wednesday night. Now you're going to the bar. Maybe you're not going home on time every night. And so as soon as you get off of work, you're going to the bar. And you start to use substances repeatedly, even when it's physically hazardous. So you're getting so drunk that you know you should not, okay, you shouldn't drink anything and then drive, but you were getting to a very high blood alcohol content and you're still driving home. You continue to use alcohol despite knowing that you have a persistent and recurrent physical and psychological problem that is likely to be caused by the substance. So you know what is happening and you know that it's getting worse because of your use. You need more of the substance to get the effect you want. And there's your tolerance. You're having to drink more and more and more to get the effects. Let's see here. And the last one, there's the development of withdrawal symptoms. Again, if you haven't used in 12 hours, 24 hours, you start getting jittery. Maybe you have anxiety, and that can be relieved by taking more or drinking more alcohol. So based upon that, 2 to 3 is going to be mild. Again, in the last 12 months, these criteria can be met. 2 to 3, moderate, 4 to 5, severe, 6 plus. Okay. So specifically with alcohol, we'll just talk about a couple of things here. And with alcohol withdrawal, the symptoms usually develop about 4 to 12 hours. I know what I just said, but right about 4 to 12 hours after the last use, people will start to have withdrawal symptoms. That's why with some people who are very addicted to alcohol, you know, they may drink in the morning, then they'll drink over the noon hour during their lunch break. That's about the time where they could start to feel some withdrawal symptoms. Let's see. Prevalence rates. And again, this is one of those drugs that is extremely acceptable in our society, even though I just got done telling you that it's one of the most dangerous drugs, especially in regard to the withdrawal effects. But it's absolutely acceptable to use alcohol in our society, even though it's incredibly damaging and can kill people. It's very common. The chance of you developing an alcohol use disorder in the United States is right around 30%. So 1 out of every 3 Americans are going to have an alcohol use disorder at some point in their life. And to break this down, 8%, about 8.6%, so almost 9% of these are going to be mild, 6.5% are going to be moderate, and 14% are going to be severe. It's greatest among men, so about 36% of men will develop this and 22% of women will. Among, let's see here, kids 12 to 17 years of age, the chance of them developing an alcohol use disorder in the next year is about 5%. So 1 out of 20 kids aged 12 to 17 will develop an alcohol use disorder in the next year. 16% among individuals 18 to 29 years of age, and those over the age of 65 is 1.5%. Okay. Trying to find others here. In regard to suicides, there is about 7 times. Yeah, with acute alcohol use. So this means that somebody's using alcohol now. Obviously, there's other variables at play, but somebody that is under the influence and intoxicated, say right now, they have a 7 times higher chance of attempting suicide than somebody who is not drunk. Okay. Let's see what else I got here. Okay, so while we're at it, maybe we'll just do this. We'll just roll with alcohol. If you'd like to look at the other substances, go ahead and check it out. It's almost all, except for like the intoxicating and withdrawal effects, they're all pretty much the same for the most part, but you can get into the DSM and check that out if you're interested. But with intoxication, we're looking at, the development of a reversible substance-specific syndrome due to the recent ingestion of substance. So even with alcohol, I mean, let's say 6 hours ago, somebody, or 6 minutes ago, somebody drank alcohol. And so they have recently ingested the substance, and there is a clinically significant problematic behavioral or psychological change. So in regard to alcohol intoxication, maybe aggressive behavior, their mood has changed significantly, their judgment, maybe they're more impulsive, and they have one or more of the following signs or symptoms developing during or shortly after the alcohol use. And you just need one of, and this is on to C here. So for C, you need one of the following 6: slurred speech, incoordination, unsteady gait, nystagmus, issues with attention or memory, or coma. One of those 6 is what is needed for C. And the signs or symptoms are not attributable to something else. So again, they've recently used alcohol. There is clinically significant behavioral issues, or there's changes. They're not acting like they normally do, and they have at least one of those signs and symptoms. Okay, so then we have substance withdrawal, specifically with alcohol. Okay, so for A, the individual stops using or reduces the use of alcohol. And there's behavioral change. Again, you're going to need that behavioral change to even kind of get an idea that there's something wrong. So you need 2 or more of the following. And again, this is the part that's going to differ from substance to substance, because everything creates kind of different withdrawal effects. You need 2 or more of the following developing with several hours to a few days after the stopping alcohol use. So autonomic hyperactivity, so like sweating or high pulse rate over like 100 beats per minute, hand tremors, insomnia, nausea or vomiting, transient visual, tactile, or auditory hallucinations or illusions, psychomotor agitation, so not being able to sit down, anxiety, and seizures. So if you have 2 of those, as a result of stopping using alcohol, you are probably in a state of withdrawal. And the signs from criteria B, they cause clinically significant distress or impairment in some aspect of one's life. And they're not attributable to some other medical condition. And I mentioned seizures and how dangerous those are. It is in approximately 3% of individuals who do withdraw from alcohol, but that is still very concerning. Let's see what else I have here. Okay, so again, you can go back through the DSM and look at all of the other substances if you would like to check those out. All right, let me see what else we got here. Okay, then we get into alcohol specific. Okay, just a few more things here. Addictions do co-occur with physical and mental health conditions with extreme regularity. So what you will commonly see is like and a lot of it does have to do with coping to a certain degree, and there's other factors, of course. But for somebody who may have an anxiety disorder, they may also have an alcohol use disorder, because when they drink, their anxiety levels are decreased. And there's a vast array of reasons. That's just one. But psychologists regularly do interact with clients and families for whom the addictive behaviors can cause significant stress. So here's the thing. When thinking of your clients and different services you can provide, consider what is the likelihood of seeing persons with substance use or addictive behaviors, whether mild, moderate, or severe. And again, you always ask about them. Can you recognize the overlap in comorbidity or co-occurrence with other health conditions? And again, some psychologists might not be aware of this, but they commonly occur together. So if there is a psychological disorder, it would be a good thing to consider their history of substance use or current substance use to potentially address that as well. Okay, I'm going to see what all we have here. Okay, we'll drop down there. After. Sorry, we have so much here. Okay. We do have gambling disorder too. And when it comes to gambling disorder, these are chronic difficulties involving the use of or engaging in gambling behavior, causing extreme distress or impairment of functioning. So in regard to gambling disorder, again, there's clinically significant impairment or distress, and you have to have 4 or more of the following, again, in a 12-month period of time: the need to gamble with increasing amounts of money to achieve the desired excitement, being restless or irritable when you cut down or stop gambling, making repeated unsuccessful efforts to control, cut back, or stop gambling, being preoccupied with gambling, again, persistent thoughts of reliving past gambling experiences, planning the next adventure, thinking of ways to get money to gamble with, often gambling when feeling distressed, after losing money, returning another day to get even, lying to conceal the extent of involvement in gambling, potentially jeopardizing or losing a relationship because of gambling, and relying on others to provide money to relieve desperate financial situations that are caused by gambling. So to have a mild gambling disorder, 4 to 5 of those need to be met. For a moderate, 6 to 7, and for severe, 8 to 9. Okay, so also, if you want, you can go ahead and roll through all of these. We have a little bit more with co-occurring disorders, if you're interested in that. Okay, there is some treatment. Okay, let's see here. Treatments for substance use disorders. Again, there's a lot of content here. We have 80 slides. So I know I'm only going over some of them. If you'd like to go back over the rest, you're welcome to. I only test over the things we go over. But again, if you'd like to go back and check the rest out, feel free to do so. So there's some treatments for substance use disorders. There's biological treatments. And this might, they basically help manage the withdrawal symptoms. So you might have methadone, buprenorphine, and Vivitrol. This is going to be for opiates. So you're going to have that for like heroin, morphine, oxy, and or Suboxone as well. Vivitrol is something that is injectable. And so this can be given about every 30 days and helps with those withdrawal effects, making it more manageable to come off of something like heroin. You have Antabuse, naltrexone, and acamprosate for alcohol. And when it comes to like Antabuse, that's a traditionally used one. It just doesn't work for everybody. But what it does is when you take Antabuse and you try to drink, it makes you incredibly sick, thus increasing the chances that you don't use again. Again, so you can see, and again, naltrexone, you're seeing that used because both of those are depressants. For nicotine, you have like Wellbutrin, NRT, Chantix. I'm sure you see some advertisements for those. And it is important to be aware of these medications in comorbid clients since they have interactions and implications for treatment. So you have to make sure that these prescriptions are not going to negatively interfere with any sort of psychotropic medications that an individual is on, because nicotine increases metabolism of certain psychotropic medications. Methadone in high doses can produce drowsiness. Chantix can produce vivid dreams and depression. So you have to take that into consideration when prescribing these medications. But combining them is often an important part of recovery and a standard of care. So some psychosocial treatments for substance use disorders. Again, behavioral treatments based on aversive classical conditioning, that would be like the Antabuse, and it can be done or used alone, or with medication. Cognitive treatments, So interventions based on the cognitive models to help clients identify, again, this is your cognitive behavioral therapy, situations in which they're most likely to drink and lose control over their drinking. So we're identifying them and putting basically like safety plans in place and their expectations that alcohol will help them cope in those situations. So looking at actually what happens when they use alcohol, does it actually help them cope? Or is something else happening? Also, motivational interviewing. So this elicits and solidifies clients' motivation and commitment to changing their substance use. And with motivational interviewing, we use what are called OARs. We use open-ended questions, affirmations, reflections, and summaries. So it's just basically getting people to talk through what they believe to be their rationale for using and potentially helping them see some of the flaws in their logic. There's also relapse prevention. And again, if this isn't, they're in a program, abstinence violation of effect. There's a sense of conflict and guilt when violating abstinence and tendency to attribute a violation to a lack of willpower and self-control. If that is something that somebody perceives, that's going to contribute to a relapse. Whether we like it or not, relapse is part of, it's part of treatment. It's part of recovery. More likely than not, it's going to happen. Maybe a multitude of times. It is part, it's part of that cyclical recovery. And to say that and to shame or to look down upon somebody that relapses is only going to contribute to further relapse. And that's why we have these relapse prevention programs to teach people who abuse alcohol or any drug to view slips as temporary and situationally caused. There's also AA, NA as well. Gamblers Anonymous is out there. I know there's others as well for individuals to be a part of additionally. So let me see if there's anything else. We already talked about gambling disorder. Okay, the last thing, this is a potential disorder that might be considered for the next edition, internet gaming disorder. So this would be like your World of Warcraft, Fortnite, trying to think of some of the other ones that are popular, but multiplayer games that can take on a pathological quality affecting well-being. And this is going to include, again, same thing as any of the disorders that we've talked about today: persistent engagement and preoccupation with gaming, tolerance, withdrawal, loss of interest in other activities, clinically significant impairment and distress in one's life as well. So I would not be surprised if this would be one of the disorders that would be added in the next DSM. So with that being said, that's where we're going to stop today. I know this was a little bit choppy, but if you have questions, if you think I missed anything, if you have questions about anything else that you might have flipped through that I didn't catch, let me know. I'm happy to discuss any of them. Otherwise, I hope you all have a great day, and I will talk to you soon.